welcome to Season 3, Episode 3 of the Strength and Chiro podcast. I would like to introduce my co-host. Some call him the Tony Stark of chiropractic. I call him Dr. Stephen Redmond. Some say Redmond. Welcome to your own podcast.
Thank you.
Well, we got that out of the way. How you doing, man?
Pretty good. How are you? How are all of y'all?
We're really good. And so next I'd like to obviously introduce the living legend, Dr. Andrew Locke. Welcome to the podcast.
It is such a privilege to be on the Strength and Chiro podcast.
Privileged to have you here.
The honour is mine.
And we've just done a 2-day workshop here in Auckland, New Zealand, which was fantastic. Good group of people.
A great group of people. Auckland has good people coming to these shows. There's no doubt about it.
Not too bad.
Yeah, inquiring minds, great questions. All questions are great.
Unless they're asked in the last hour of the last day.
Something that should have been asked in the first hour. And nobody did that. They all asked a good question in the last hour that should have been asked in the last hour.
Very true. And then introducing back to the podcast, Dr. Luke Gichard. Welcome to Strength and Chiro. How's it feel to be back?
Good to be back, man. It's always good when we're back in the groove, you know?
Yeah.
Getting stuff done, making stuff happen.
And this is a little bit different because we have 3 of us obviously here in Auckland on the line here, and then Stephen in the US of A.
In what state?
South Carolina.
South Carolina.
South Carolina. Wow.
I was going to say North Carolina, South Carolina.
How good is that?
Why did I think it was North? I got mixed up. It's okay.
Woodbury's in North.
I think Michael Jordan played for North Carolina, didn't he?
He did.
Yeah,
Michael Jordan.
That's why everyone knows North Carolina. Yeah.
Before the Bulls.
Yes, before. That was his college.
Dogs, yeah. President.
Oh, the dog, yeah. Can we get a dog cam? See, it's a cute dog, eh, Locke?
How's that? Well, from this distance here, it looks like a blob. Don't worry.
Looks like a black dot. Hey, I would, special mention after the workshop
Yep.
to Sui and Krista, who were chatting to us and listened to the Strength and Chiro podcast. So I give them a special mention.
They absolutely deserve a special mention too.
They asked great questions.
Oh, yeah.
Great participation.
Superb. Absolutely superb in the prac work too.
Really good. I mean, it was a really good few days. Dr. Stephen, how was the conclusion of your studies, your postgraduate studies that you've just finished?
Oh, that was good. Yeah. Yeah, all that went well.
So tell our listeners what tool you've added to the toolkit.
It's not like there's really just one tool that I took away. It provided more information, made me doing the things that I was already doing. It made me more confident with more rationale for why I was doing some of the things I was doing. And it did show me some slight differences in ways to approach things.
And does it open up any other opportunities for you?
Not like it doesn't give me anything new. I don't get an increased scope of practice or anything like that. But I'm lucky enough that one of the people that helped create the program did recently move down here at the same time, and he works at a hospital system, and they don't have chiropractors there, and they don't have anyone trained in the training that I've done. So he's been referring people to me since before I finished it.
Nice. Well, that's good.
It is something when you get information that isn't necessarily specific to one thing, but opens up an understanding of many things that you do.
Non-specific information.
Non-specific information. Well, it could be specific information applied to many different specific situations.
Not non-specific back pain.
Nothing in life is non-specific.
Exactly right.
It only appears that way when you don't know anything.
Well, hey, this is Strength and Chiro, and I mean, look, one of the main hallmarks of the chiropractic profession is manual therapy, manual manipulation, right? There's no
and isn't that in itself specific?
Can be.
Well, in the mind of perhaps the determination of what treatment is going to be applied, I'm sure that in fact it requires that the individual identifies something specific to which chiropractors will intervene. I actually like that. I think that's really good.
But one thing that many people don't know, and I think I saw a few surprised faces when you said it at the workshop, was actually specifically what your master's is in. Do you want to tell us our strength?
Manipulative techniques, yeah.
Of the axial spine.
Yeah, that was it. Only axial, nothing peripheral. It was all spinal manipulation. So it's a master's in manipulative therapy.
And that was 2 years, and you were working in hospital doing block course hospital stuff?
Worked in hospital. Yep. In that, we were doing fully orthopedic work as well, which was integrated.
And so tell us, what are some of the key things you...
All right, here it is. All right, there's been
two
two defining pieces of information which have enhanced my career. So here I am in the hospital. It's a general hospital in the orthopedic area, and mostly the outpatients who are coming in. And after 1 week of working there and making people better, then the next week comes and I walk in on the first day, on the second week, and the head of the department pulls me into the office and said to me, "Stop fixing people." And he goes, "Because you're supposed to be here to learn." And he said, "All you're doing is all you know works." And he said, "These are hospital patients. They're here for you to learn from. You're not here to actually just get them better." And he said, "Now you're banned from doing any technique and any theory that you know works. Now you must do everything you don't believe in and everything that you've dismissed. This is what you must apply."
Was this post your McKinsey training or pre?
Post, well and truly post.
Okay, so you had the McKinsey stuff down.
I'm banned from anything that I know works.
Okay, so none of that's preferential movement stuff.
No, I have to now apply manual techniques. I have to do things that I've dismissed.
Wow.
Now, that's the biggest learning thing for the rest of my life is when you get good at something, your career stops unless you start examining the things you don't know.
Yeah.
And that's life. And that's every day in clinic, even when I'm there. I will do something I've never done before at some point, whether it's within an assessment, reassessment, whether it's within technique. And it might only take 30 seconds to do a reassessment of something that I did not believe was related. But that has then enhanced my ability to see if something changed that I never expected and I had assumed would not change. The assumptions are what get in our way of progressing our careers.
Absolutely.
So there it was, the best piece of information I got, which was always test what you don't believe in, always learn.
I suppose the importance of always moving forward in education and coming off the back of what we just did in this weekend. And Luke, I would say relatively new grad. What was it like? So you've got your chiropractic qualification, you've got the DR in front of your name now. Whoop-de-doo. What was it like coming into this kind of continued education environment where you got one of the best in the world teaching you for 2 days, like Dr. Locke? What was it like?
Yeah, it was great, man. It's like a real different pathway and avenue, obviously, from traditional chiropractic. But at the end of the day, it's the real world, You can't fall back on your 1 or 2 techniques that you learned in college. And back onto what Dr. Locke was saying before with trying the things that you don't know works and then retesting. So, for example, yesterday, I think a couple of good moments that everyone would have found quite interesting was using the single leg Rombergs to improve lumbar extension.
Yeah, good one.
Within 30 seconds, it's just again something that you didn't know would work. You test, you apply the intervention, and then you retest and see what happens.
And then, of course, what you got to figure out is why the hell did it work?
Yeah.
That's the beauty of it. Well, that just works, and I've got no actual backing of what just happened, and now I've got to figure it out. That's what I love about it.
Now you got to answer the patients why.
Yeah.
No, don't worry, the patient thinks you knew what you did in the first place.
Well, that's what you want them to think. So what is the why behind that, Dr. Locke? Do you want to drop us some
Well, it's
knowledge?
proprioception.
Pretty cool stuff.
That's it.
Yeah.
Yeah, that's the beauty of it. So you've improved it, basically, should we say, activated the proprioception to prepare for movement better.
As a cool little movement hack, and I think everyone kind of bought in at that point. It was people were like, "Oh, whoa, let's try it out ourselves."
Yeah.
It was really cool. We actually had Alex Flint, who works on TV with some of the All Blacks here, and he was right into it. He's a powerlifter, and he was loving it. And Dr. Locke was getting him out front to do like different movements. It was cool to see the different types of people that were there, the questions that they were asking. And I think we had chiros, physios, exercise physiologists, trainers, coaches, CrossFit coaches, and everyone seemed, the gaps. It's the gaps. It's filling the gaps. Remember, that was the first thing they said on day one. And we've talked about this before, Stephen. We connect across the globe constantly with different people. And so many times we've said it, there's these consistent gaps in curriculum. There's these consistent gaps in education. And you find when you get people that are they understand the evidence, they understand the clinical principles, there's almost like this amalgamation or this converging of techniques and converging of clinical skills that happens. And you get like-minded people into a room that have different letters after their name, but their thinking becomes so similar. And I really like that.
At the end of the day, they've all come from different paths, but they haven't left the institute drinking the tea, first of all.
Yeah.
So they've all come with really good questions and just wanting to get better. They've left the ego at the door.
Yeah.
And just wanting to learn. So that's what it's all about.
And exactly what you're saying is wrapped up beautifully by what Dr. Locke always says, lose your religion. What do you mean by that?
Yes, the moment you graduate, lose your religion. And your religion means your professional definition of who you are. So if you have graduated and you're a physio, well, stop being a physio in your mind and become a health professional. And that means if you're a chiropractor, well, you have your degree in chiropractic, but now you are a health professional and you can learn from the physio, the chiro, the osteo, the myo. You can learn from the Chinese medical acupuncturist. Yeah, we all now have things that in our own areas are good, but they fill in gaps that you didn't get. I learned so much from the chiropractors I worked with over the years. Yeah, we learnt things too regionally when I was in physio, but you didn't see things in systems.
That's really interesting, isn't it? So it was almost not specific enough from what you're coming from.
You were taught a hip.
So you enjoy the specificity of chiropractic.
I love it.
And then as chiropractic, when we were in chiro school, like we were taught so much specificity that we rebound from that and we look to the research and we're like, oh, Justin's not specific. And it's so funny how you peter-patter between these ideologies.
At least the one thing that chiropractic got right is their philosophy right is treating the body as a whole, right?
Yeah.
So it's like when you have a knee problem, could hurt, look at the ankle.
Yeah.
So they didn't teach us that, but it's the idea of that.
The idea of that, they didn't teach us it. But yeah. I think when you refer to your acupuncturist, you write down the one thing they have to check out, which is Ren 1, right?
Ren 1, yeah. All good acupuncturists will check Ren 1. Always good to add to your toolkit.
So, Stephen, tell us about an interesting patient you've seen in the last 2 weeks.
I've had this guy come in. He got an X-ray, showed a pars defect, and could barely stand up, could barely sit down. I was seeing him twice a week, and then on the third visit, also, he was given prednisone. He chose not to take his prednisone. Things got progressively worse. I was like, "Why aren't you taking your prednisone?" He took his prednisone. He was able to move around a little bit better, and then 2 days after he started the prednisone, he started developing an antalgic lean, and he was like, "I don't know what's wrong with me." I was like, "Well, you've got probably a pseudo disc herniation. There's definitely a bulge there that's being irritated by the irritated spondy as well." So went through some movement proficiency stuff with him, showed him how to move, showed him how to offload his own symptoms, and he went from barely able to sit down to being able to sit to stand and go home and continue doing those for, I believe, 4 or 5 days before his next follow-up.
So there was an interesting one. You had a patient who had not followed directions, and then you reinforced there were directions for that person to follow.
Yeah.
Isn't
And
that
then they actually shot me a text 2 days ago because we're at 5 days in between visits. And they were like, "Hey, it's starting to bother me. What am I supposed to do?" And I was like, "The exercises we've been doing in the office." And I told him to do them. And he's like, "Okay, all right, yeah, that works."
that is a classic. That's just an interesting one. Julie, my wife, she had a very interesting case. A person came and saw her for a hip. And Julie said, twice a day, every day, you must do these things. Twice a day, every day, this amount of repetitions. Well, pretty much the number she was saying was exactly what most people get. The frequency was what people get. So she rang up the patient the next day to say, "Oh, well, how'd you go? How's the exercises going?" And the patient said, I do them 4 times a week, don't I? And he was going, "I've never prescribed 4 times a week to anybody. Where'd you get that one from?" So, yeah, the assumption that a patient actually listens to what you prescribe, that's sometimes a failing because you think they got it. And then, I gave you some exercises to do. "Oh, you mean I was supposed to do the exercises?"
Yeah, exactly right. Got to get them to understand and repeat it back even sometimes.
Yeah.
It's a hard one. You don't want to act silly. You don't want to treat them like a child, but at the same time, you see that pattern of people that don't fully comprehend.
It's funny with the patients where you're giving them exercise as a homework and as a symptom modulation tool, and they do it with you and they buy into it and they're like, oh yeah, this works. And then you leave the picture and they're like, oh my God, what do I do? And I've already given them the answer and they forget. They're like, wait, he didn't do anything. He gave me exercises. Like, I didn't adjust this guy. I didn't scrape his
Interesting.
muscles. I didn't do any cupping. I had him do exercises. And then
Interesting.
he
Yeah.
has to get that aha moment. Wait, yeah, he didn't do anything to me. He gave me exercises and
Mm.
I was able to move much better. So it's funny.
Perhaps what you see there is actually the patient's mindset is similar to the adjustment. I came in, I got exercises, I got better. I go back for another exercise session and I'll feel better again. They're
Yeah.
taking it like an adjustment. Okay, I'll go back and see them do that again.
Yeah, I mean, hopefully, because it's funny because what you're saying, it's like some people have this mindset of like, he didn't do anything. He gave me exercises. He didn't do anything. I know, Luke,
Yes.
you've been navigating this, the line between integrating those active and passive techniques.
Yeah, it's been challenging. Spoke about it a lot in the workshop, like trying to find the fine line between meeting the patient's expectations and what they perceive as necessary for treatment and intervention, but then also using what you know works and is what's going to be beneficial long term.
Mm.
So I've had it heaps with different tendinopathies, like elbow tendinopathy, like cerebrospinatus tendinopathies. Like if I get them onto isometrics after a couple of sets and then retest and there's no pain, you get that kind of buy-in. But then other practitioners will just be spending sessions sticking needles in, hands-on, and like to them, that's probably what they expect or what they perceive as quality or more value. So yeah, it's trying to find the fine line between using a little bit of both, I think, when necessary.
And do you find patients buy into the exercise or do they buy into the passive interventions?
I think the exercise more when you get a patient where you don't even have to essentially apply any hands-on to that area,
Mm.
and then you apply a couple of exercises or one, and then you retest. They move a bit better. They've got more strength, and then less pain as well. I think they become more shocked with that versus applying hands-on and reducing symptoms. I think remember that patient I jumped online with you, and he had the knee problem, and you covered pretty much a basic abdominal brace.
Mm.
Tongue to the roof of the mouth, shoulders retracted back and down, creating stiffness around the abdominal region. And then he stood up and he had no knee pain. And he was kind of like, well,
Yeah. It's like a magic trick.
yeah. So,
Muscle testing.
yeah.
Magic.
Like last night, I did some muscle testing on Dr. Locke last night, like the classic, like test, and then like swipe the C2 test. Like it was a bit, it was a bit of fun. But yeah, patient buy-in, and I talk about communication, education, compliance. That compliance piece can be difficult when people perceive your profession as giving you one thing and they walk in and they're doing something else, or you're doing something else. And over the weekend, I had people say to me, like, okay, well, like chiropractors adjust, right? Like that was kind of when they were talking about chiropractic. And I was having a good chat to Lewis from Whakatane CrossFit, awesome dude. And he was like, well, like that's the philosophy of chiropractic. So what is chiropractic outside of that? And I was like, well, that's a really good point because there's parts of the world where chiropractors are very progressive. And then I'll be like, oh, they're evidence-based. And then it's like, well, what's that? What's evidence-based? So it's like, well, maybe they're evidence-informed. But for you, Stephen, this is an interesting question for those listening. What is the differentiation between someone that doesn't know? Okay, they just think a chiropractor adjusts. What is this maybe forward-thinking, integrative new chiropractic that you practice and Luke practices and etc.
It's honestly what Locke said. It's being a healthcare provider. Like in my bio on Instagram, someone brought it to my attention that I don't call myself a chiro, and I don't. I call myself a musculoskeletal provider and educator, and that's what we are. And to do that, we have to use whatever we have at our disposal. Whatever
Mm.
we know we can do, we apply it. We
Mm.
don't stick to just the one thing. Also, kind of back to what Locke said about his time in the hospital where he had to figure out what he didn't know and had to learn from that. Like we have to apply that if we do go to a school where we are taught just one or two things, then it is our responsibility as a healthcare provider to go and learn those extra things and apply them. Otherwise, we're just a chiropractor, we're just a physio, we're not a healthcare provider.
And that's why we're really talking a bit about Professor Stuart McGill as being a man without religion, because a lot of people realize he's a professor. He was a professor of biomechanics at Waterloo University, but he was an engineer prior to that. He was not a chiropractor, a physio, an osteo, or whatever. He came into it without being tainted by a philosophy outside of physical and physics reality. And then he had to apply it to a human body. And that's why I think he has such clarity, because he isn't infected by a philosophy.
I very much agree. And I think for those that are listening that haven't looked into his stuff, and I know for us, it's like McGill's like standard, but for some people, they have not heard of McGill. So if you're listening to it, Stuart McGill, lower back disorders, get it in your hands, read it, digest it, read the research. I say this often, but it's because people always ask me, what do you suggest I read? What do you suggest I look into? And I say, have you looked into McGill? Have you looked into McKenzie? Have you looked into Aaron, Kelly, Locke? But funnily enough, Stephen, you gave a lecture to a bunch of my friends probably 4 years ago. And I remember you saying, on your slide, you said, if you have not been told about this man, your university has let you down, extremely let you down. And the person you'll talk about was Robin McKenzie, because he was a Kiwi, of course. And I think all of my friends were like, what? Like, who, what, where? Like, who is that person? And you can get the book. I was showing Dr. Locke you can get like the pack of all 5 books. And to tell him what you thought about that.
I met Robin McKenzie and had presented at the McKenzie International Institute's World Conference.
Yeah.
So it was wonderful to meet him personally. But all I ever learnt was the axial skeleton work. And I'm pretty sure that's all he actually wrote. But the pack of self-help books also included shoulder, hip, and knee. I'm sure he didn't do those. If you are a professional and you're wishing to improve your education, they're great for you, but they're little golden books, okay? That's their level, which they're really pitched at. It's pitched at Gen Pop. You have to buy Lumbar Spine Mackenzie's 2-volume set for professionals. And that's where you will grow.
That's where it gets going.
Yeah.
And even in the workshop just gone, you were touching on those principles.
Yeah.
How important do you think it is for someone just graduating to get their hands on those books and understand those fundamentals behind what McKenzie established?
If you've graduated, you must get the McKenzie 2-volume lumbar spine set.
Like the clinical textbooks-ish.
They're professional textbooks. Yeah. That's where I've got 2 different versions. I got the first editions, beautiful little things. And then there's the later editions, which are massively expanded, massively more information in them. So for me, that was if we talk about like the concept of being influenced by what you were taught. McKenzie had that wonderful opportunity where I think it was 1957, where the patient walks in and the patient had back and leg pain and had back and leg pain for 2 years. And McKenzie said to the patient, go lie down behind that curtain on that bed there, face down. And what McKenzie had not checked was that the bed itself was bent at 45 degrees because there was a knee patient had been in there prior. And of course, his patient goes in and does exactly what he's told. So what a good patient. Lays face down, stuck like a banana. And nobody had ever done that before. And of course, McKenzie walks in 5-10 minutes later and sees this patient bent into an obscene position. And the patient just turned around to him and said, you're a genius. It's the first time I got rid of my leg pain in 2 years. Now, in that thing, he's got this sudden opportunity where he's not been influenced by anything else previously, unless he read Williams' flexion exercises, which was going to tell everyone to do the damn opposite, pull your knees to your chest, which I expect that patient had been doing for a few years, which was once again the direction that was perhaps continuing the patient's symptoms. And by that experience, we start to understand directional preferences and physical loading upon a passive structure.
Mhm.
Well, you know what? We deal with passive structures a lot in the axial skeleton. So if you understand how a passive structure behaves under certain positions and postures, you start to understand how you can vary those positions and postures to get a person better.
Exactly.
So I love that about the Mackenzie approaches. I think he's almost got to be at that point without religion because he had to start his own one.
It's interesting how you describe that because it's very easy to go on social media and to get when you listen to other so-called self-appointed gurus, to get the feeling that lower back disorders or lower back problems are just complicated and hard to understand and always, lots of red flags and lots of issues. And it's just made out to be this hard thing. And hearing you talk about it over the last 2 days actually really opened up my mind and went like, you said you say it better than me, but there's nothing new here. Now, I don't have the experience you do, which I'd love for you to share with our listeners about your experience in the cadaver labs. We only got to go to the lab once in our experience.
Very short as well.
It was very short, and we were monitored. And so tell the listeners about your experience,
Yeah.
and then tell them why it's all there.
Fortunately, my undergraduate degree, we spent 2 years in human dissection as one of the major parts of our coursework, but you had unrestricted access. You had 24-hour access to the university cadaver labs. And it was not uncommon for me to be in there 11 o'clock at night, 12 o'clock at night, and 40 different bodies under there, steel tanks with heads in them, arms in them, legs in them. And you got your dissection manual out and you're looking at things and you're working constantly. And you're doing that almost on a daily basis. And then the master's degree, I got another year of doing it. And it is that familiarity that you realize there is nothing new in the human body which has not already been discovered. There is no muscle we don't know. There's no passive structure. There's no active structure that doesn't exist. It's not a mystery. And in fact, it's not actually too much of a mystery how it behaves either, because physics actually tells you what happens to a hydrated structure. And it tells you how a muscle attaches here and a muscle attaches there, and how it brings two ends together, and how it may stabilize, and how it changes when the joint angle changes. There is no mystery in lower back disorders. There is behavior. Well, in some respects, that's not even too mysterious either, because you can identify it. And physios seem to think that there's some sort of freaking behavioral health professionals these days, and they don't have a degree in it. My thing there is, if I see someone who has behavioral issues that I can see biomechanically that nothing is actually influencing this more than the person's psychosocial interaction, guess what? I refer them off to someone who does that. Like they have a degree in behavioral health.
Yeah.
They can diagnose that condition. That's what we do.
I mean, the way you describe that is brilliant. And when you look at the research, it is shocking to see that 1% are red flags, 5 to 10% ridiculous issues, and the rest, 90%, is just shoved into the medical abyss of non-specific back pain. And that is a massive problem.
It's a massive problem in everything. If you run a business, and it's not even healthcare, if you ran a construction business, if you ran an accounting business, nothing is non-specific. You can't build a building non-specifically. You couldn't do your tax return non-specifically. You can't assess a human being non-specifically. If you want to be a success in whatever profession that you are doing, you better be good at specifically figuring things out.
And a non-specific lack of diagnosis will result in a non-specific treatment or intervention that likely is not very helpful.
Guaranteed to be not helpful. Though, when we remember the statistics on lower back disorders, in low back pain, 80% of people are better in 4 weeks. So you can be non-specific as shit and you're still going to get a 80% success rate, and you're going to think you had something to do with it.
Just be around when it happens, right?
Be there when that happens, and the patient will think you had something to do with it.
Just hang around with them long enough and they'll get better and you'll look like you've done it.
Yeah, that's it.
Whatever you prescribe, Pilates.
So it is intriguing.
Yoga.
I think that's where a lot of people actually get in their professions is the patient gets better within 4 weeks and they actually think they had something to do with it.
Yeah.
Well, possibly they did. But statistically, they didn't really have to be there.
Exactly right. Kind of just self-limiting.
But what it is, it's preventing the 90% recurrence rate that shows you're a real professional, because of course the patient's going to heal. But guess what? They're going to do it again unless you identify the cause.
Stephen shared an interesting story about the spondy. Could you share an interesting story, a patient story from your experience?
Every patient's probably, to some extent, always interesting. That's the beauty of it. I always say we're apex predators. We're hunter-gatherers, but we're only dominant species because we are apex predators, which meant we were able to look at movement. We would look at a herd of animals and you'd pick which is the weakest animal there, and that would be how you'd plan your attack to get the tribe together or get yourself together, and you figured out that was the weak one, that's the one you're going to go for because you're seeing a dysfunction in that creature. Well, we've actually got that in our ability. We are very good at discerning and seeing things when you realise you can see things very well. Or you can be very good at hearing things very well. And as a professional, sometimes you get really good with your handwork. So it was interesting. I had a patient walked in one day and I just looked at that gait pattern and I thought that person doesn't seem to have a good sense of position of where their body is. And although they may have had a disc bulge experience or a disc injury, it was so far in their history that I could see that this person had never actually restored their sense of position in space. And this is one of the little ones I do quite often in the practice, is I get the patient to stand up and there's a wall there with a marker behind it, and I get them to close their eyes for 30 seconds and stand there, and you can see that the way people have got a lower back disorder, their upper body sways forward. The person who doesn't, they'll just stand there really nicely. And when you see that, you go, there's a proprioception, there's a missing part of that person's understanding where their body is in space. When I saw this person walk in, it looked like a disordered gait, but his history was only lower back issues. And so I actually made pretty much like a bird dog. I made him shut his eyes doing a bird dog. I wanted a proprioceptive bird dog. I did the single leg stance work. And realistically, all the other work I did was, yes, finding there were weaknesses. But when I saw him walk in a week later, and I see him, don't worry, I see him twice a day for a week. That's the beauty of working with certain contracts. He walked like a normal human being. And I realized what I'd seen on day one, which was the disordered gait, was correct. He didn't know where his body was in space very well. And that's something we don't get a lot of understanding of, but it's your ability to assess and see, like McGill does. You watch how a patient walks in the door. Hell, sometimes you can hear him walking and you go, I hear that leg drag, or there's an uneven gait coming before they even walk in the door. Yeah. And that's our beauty of assessment. I think that's what I love. That was the assessment moment and going, yeah, I saw something there. And that was there. But it could be you hear something too.
Yeah, it's interesting, how McGill talks about like looking through the blinds as they're getting out of the taxi.
Yeah.
Like walking up as the drive or whatever it is, like looking at the gate and you try to, figure things out.
See, what a predator he is. What an apex predator.
He's pretty good, isn't he?
Yeah.
Dr. Stephen, how are you going personally with the management of your own spondy? Because I know that you're currently managing, working with it, through it constantly. And does that, I'm sure people will be interested to hear how that interacts with your ability to work with patients, leaning over people every day or working or...
Yeah, so I stayed very active, thankfully, with my career choice. And then I work out, I lift weights, resistance training is paramount, as well as learning able to unconsciously or subconsciously create that intra-abdominal pressure to have all of those muscles stabilizing. So every time I lean over, there's not the drastic instability, because it is unstable. It's unstable, but there's not, every time I bend over or lean backward, there's not an immediate neurological compromise because things are working the way they're supposed to. And I do share that story with patients. Usually they come in with really severe pain and they think their life is over. Or if they're like that patient that just like, no one understands, you don't understand, you're not listening to me. I don't even want to be here. And then I sometimes have them just sit down and be a little mindful for what's going on in their life with their condition.
What's your best strategy for getting people to be compliant with what you prescribe them?
They will figure out that they get better when they do the things I tell them to. And that usually builds some compliance. It can take some time because they're like, oh, you fixed me, I'm good. And no, it's a long-term thing. Like, pain is cyclical a lot of times, especially chronic low back pain. It's going to flare up again if you do the same things you're always doing. So either you have to stop doing those things or you have to add these into your daily routine. And most of the time, people don't want to stop doing things. I don't want to tell them to stop doing things unless it's absolutely detrimental to their health. So they have to learn that this is just a part, this is like brushing your teeth.
Compliance is
You need
is
to,
obviously everything, isn't it? You can have the best
yeah.
solution in the world, but if they don't do it, it didn't work. I have a little compliance one that really works quite well. Is when a patient finishes that first appointment, I tell them what they have to do. I write it down precisely what has to be done. Now, the next appointment they come in, the first thing to say is, show me the exercises. I don't tell them what they are. Show me what you've been doing. Now, if they turn around and they say, how do I do them again? I say, this is pretty easy, right? Say I'm charging $500 for the appointment. I'll tell you what, if you don't do them again next time, I'm charging you $1,000 for that appointment. I'm just going to say, I'm prepared for you to disrespect my work, but you're going to pay to disrespect my work. So I'll still see you. You still don't have to do them. But now it's $1,000 to disrespect me.
Yeah.
And it's very interesting. Very quickly they get that. Yeah. Okay, yeah, sure, you don't have to do them. But if you do come back and you haven't done the work, this is the fee.
Mm. And how do I mean, watching you yesterday, the way you were coaching in person, and just the harmony, or I suppose, how do we describe it? Like graceful and competent movement, I think is how I described it on my slides yesterday.
Yeah.
Seeing you do that in person is awesome. How do you achieve that online?
Basically the same way. Simplicity.
Mm.
Never too many cues. Zip my mouth. Do this.
Do you get them to put the camera facing them, get on the ground?
Yeah, see them do the work. Yeah, perform that movement.
Mm.
Do this. Listen to my voice. This is the order you are going to do this is. This, stop. This, stop.
Mm.
This, stop. That is the way you have to do it. And it's the simplicity of not over verbalizing.
Yeah.
And that's where they get lost. And that's probably the thing I've learned best is to under cue rather than over cue. Because someone was saying, like there was a side plank being done. And one of the people said, I noticed this person was sort of rolled forward in the side plank. You didn't say anything about it. And I go, yeah, at that point, I'm happy for them in the first instance to do a side plank in the way that they were getting there, but there were some errors in it. But if I try and perfect the movement on the first instance of a new exercise that person's doing, they will get lost. And I said, but the second time they come in, and they come in with that error, I know they got the basic pattern. Now I will adjust the pattern. Mm. And a lot of people are taught especially in workshops, this is how it's done perfectly, and the patient must do this perfectly. And it doesn't go that way. Motor skill learning is sometimes learning your own errors and then getting corrected. And that's an understanding. That's why I find that most people just try too hard to make it perfect. But I can make a perfect bird dog out of anyone with 3 cues, so that's cool.
I saw it.
But a side plank, that's going to be different.
Mm. I did. I was watching it. I thought it was really, really good. Another question I have for you, Dr. Locke, is for those that are listening, and maybe to bring this, I'm going to come around full circle with this question. Just context before we ask the question. Stephen, can you remind our listeners what the duration of your standard appointment time would be?
It's typically 15 to 30 minutes.
15 to 30, and Dr. Luke?
45 initial, 30 standard.
Not bad, is it?
Yeah. And so
my appointment is no less than an hour. Doesn't matter whether it's first time or reviews. Mm. And I actually usually put a little bit extra time in just in case I wish to run over.
And your first, what are your first appointments like?
Perfect.
Like time-wise?
They're no less than 1 hour. I usually put 90 minutes aside if I have to, but I'm actually going to book them on 1 hour. Yeah. But I'll actually put 90 minutes aside if I decide I'm going to go further.
Yeah.
Now, the thing today is, which I always, as we were saying in the workshop, is if you got 15 minutes, but you know there's a whole lot of things you want to do, you would look for the one thing that will make a difference with that patient. Mm. You may have 3 planes of motion that you wish to work with that patient. You may have some neurological things you have to do. You might have some passive things you got to do. You might look at a motor control thing you got to do. You're not going to get it done in 15 minutes. So what are you going to do? You're going to do the one thing that you do within that session, which makes a difference to the patient. And you put in your own notes how you're going to get through the rest of the things over the rest of the appointments. They might take you a month to complete that process. So your 15 minutes, you got to get the patient to buy into what you know is working. They see something works, you've had success. They will come back, next thing on your list, do that. 15 minutes down, good, buy-ins in, you're going through it. Next one, it could take 4 or 5 appointments to get to what you would have done in what I might get done in an hour. And even in an hour, I'm still going to write something down next appointment. So I might have got an active exercise series, but I haven't got to motor control yet. All right, making them stable, making them better. Come back. Today we're going to hip hinge. So it's all about the patient getting buy-in that you know what you're doing. So do one thing well. Tick box.
That was the answer to the question I was going to ask.
Of course.
But yeah, you went right. You knew it.
Because
where I was going.
Because this is a big one.
It's a big one.
When we're doing workshops, hey, here's how you do everything properly. Well, what therapist has got that time to do everything properly? Have you got 4 hours to spare, like Professor McGill, who might plan 4 to 6 hours? Well, that's what it takes to do a magnificent assessment and intervention. But you're not going to get that when you're running in your own practices or working for other people for quite a few years until you get to the point you can do it. Yeah, it must have taken me well over 10 years before I got to that opportunity, probably 15 years.
I'm very privileged that I am able to take referrals from you, and so I get to spend a bit more time with people, make sure I get things as detailed and accurate as possible. But it's you got to be realistic, and hearing you talk about setting aside 90 minutes, I know how you work. I'm like, you must be very efficient to do it in 90 minutes.
Well, if you look at it, if I'm charging $500 an hour as a base rate, it could even be up to $1,000, depending really what the contracts are and what I'm doing. Well, if I see 6 people that day, what have you got? You got $3,000. Did you need to pack in 20 people to get to that point? So I'm very comfortable. I'm happy to see just the ones I want to see. And I'm never going to burn out, am I?
It's a smart way, yeah.
Because I might book 3 people in one day because I know I've got a lot of things to do. So I'm going to get 3 people in that day. That's okay. So as a professional, you are getting recompensed appropriately, but you're not busting yourself to try and get to a point where you got to pay your rent, pay your mortgage, family, kids. Yeah, which suddenly your time pressure puts you into 15 minutes appointments because your rate's got to be appropriate for where you're working.
Yeah.
So there's a lot of factors in your profession which allows you to do the things you got to do. That is juggling really life and your profession.
And for those that are listening, that so switching gears away from maybe the new grads and more to the people that have been doing it for a while, and they see what you are doing on the landscape, like globally, and they want to do more of that. So that next level, the more traveling, the more workshops, the more working with VIPs. Do you have any pieces of advice for them?
Yeah, I bet you've done this, right? I mean, you in your pastoral work even, right? You're very good at presenting an hour's worth of information to a group. Well, when you first start running education, you've probably got a good hour you can present well. Well, we're at the point where we're teaching 5 days of work in 2 days. And it's still, we're busting it to really get there. So my thought is, if you're going to learn to become an educator, and you do have information which is educational, which is helpful, first thing up is you start with 1 hour excellence delivery of what you're doing, because that's probably that should be your level of excellence. You haven't got the skill to run 2 days. We haven't got the information to run 2 days. Well, 1 hour becomes 2 hour workshops. You might get to half-day workshops, and then it just builds. But don't try and pad out beyond the diamonds that you can create. So for a professional, do what you do really well.
And what's it like working with some of the best, like Matt
yourself.
Winning? No,
You did a great job on the weekend, man. That's freaking fantastic.
What's it like working with Matt Winning, Sebastian Orab?
You're working with different personalities all the time. You know the other person has certain areas of expertise, and that's your time to step back and watch why they're experts. So it doesn't matter who I present with. Sebastian's fantastic, very passionate. Q&A time's hilarious with him because we always laugh about it. He's so passionate. By the time you get to the last Q&A session, and you might have half an hour in the Q&A, that means Sebastian's got one question, and he's going to take it, and he's going to every rabbit hole that question is going to. He's filling it in with the best information, and we always laugh about it because he usually gets to go, "Shit, what's the question again?"
Yeah.
Because he's done so much in the answer.
I like it.
Matt Wenning, tight. This is it. So it's all about their personalities, and you integrate with it. You're never imposing your personality onto it. You just do your part.
Well, it certainly was fantastic doing the workshop with you, watching you work and do your thing. And there was I think the practical elements were very, very well done. And then obviously we opened up the workshop with Dr. Locke's one of your lectures. And it was phenomenal. It was very good. The buy-in was immediate. I think, hey, look, great stories, great just aspects of it, information mixed in with hundreds of slides.
Yeah. Well, I think what we do really well is within the workshop concept is I like to give people the answer of the whole thing at the start of it, and then you build back in and then you show them how you got there.
Yeah, that's right.
So you give everyone the understanding. This is where you end up. Now you got to spend 2 days understanding how to get to that point.
Yeah, exactly right.
I used to do it more that you just present the whole thing at the end, how it all tied together. But I actually think it's nice to show the whole package at the start, and then you fill it in and go back to it at the end.
And keep it simple, as you say.
It is simple. It's easy. Low back problems are easy, huh?
That's what you say. Anyway, okay, we ran out of time, but that was fantastic. Thank you very much, Dr. Locke, for coming on the podcast.
Total pleasure.
Thanks for being here as well, Dr. Luke. And awesome to see you again, Dr. Stephen. And I look forward to episode 4.
Thank you, Super Stephen. Thank you, Super Brogan.
Thank you.
Thank you for
being here. All right, see you later.
Bye.
See ya.